Hi, I'm Tan Hein, a fellow from the Department of Hematology in Singapore General Hospital. I'm going to discuss about chronic myeloid leukemia. Chronic myeloid leukemia is defined as a myeloproliferative neoplasm that originates in an abnormal pluripotent stem cell and is consistently associated with BCR-ABL fusion gene located in the Philadelphia chromosome. There is an annual incidence of 1 case per 100,000 population worldwide. Untreated chronic myeloid leukemia, or CML, is usually triphasic, an initial indolent chronic phase, followed by an accelerated phase and a blast phase. Blast phase is generally fatal, with significant reduction in median survival to only 5 to 6 months. In chronic phase CML, peripheral blood shows leukocytosis with myeloid cells in different stages of maturation, predominantly neutrophils and myelocytes. Basophilia is typical. Thrombocytosis and eosinophilia are common. 95% of CML has the characteristic cytogenetic abnormality, the Philadelphia chromosome. Reciprocal translocation between chromosomes 9 and 22 results in fusion of the ABL1 proto-oncogene on chromosome 9 to breakpoint cluster region BCR on chromosome 22. Patients with CML usually present in chronic phase with symptoms of fatigue, weight loss, anorexia, and abdominal fullness. Diagnosis can sometimes be incidental from routine blood checks in otherwise asymptomatic individuals. Physical examination reveals palpable splenomegaly in most cases. Chronic myeloid leukemia can be stratified into different risk groups by various prognostic scoring systems in order to predict survival. The most widely used SOCAL score is calculated based on several parameters, including patient's age, splenomegaly, peripheral blast, and platelet counts. Treatment of CML has evolved over time from just palliative treatment, cytoreductive therapy such as hydroxyurea, to more promising curative strategies using interferon in recent decades. Nevertheless, stem cell transplantation still remains as the only proven curative treatment for CML. Imatinib is the first in the family of thyroxine kinase inhibitors, which have created paradigm shift in the management of CML. Imatinib acts as a competitive inhibitor at ATP binding site of BCR-ABL kinase domain, thus preventing phosphorylation of its substrate. Hence, imatinib is superior to conventional treatment in inducing major cytogenetic response in CML, as described in the landmark paper published in the New England Journal of Medicine in 2003. However, there are several mechanisms by which the disease can be resistant to imatinib. In majority of cases, it is due to mutations within BCR-ABL kinase domain. It can also be attributed to overexpression of BCR-ABL, drug influx or efflux transporters, or BCR-ABL independent mechanism in some instances. For imatinib-resistant cases, second-generation thyroxine kinase inhibitors are currently available, either as standard therapy or in the clinical trial settings.